Next, we have Carly Zapata to speak with us about our hospice and fellowship program.
All right. Thanks, Jules. As Jules mentioned, I'm Carly Zapata. I'm the program director for our Hospice and Palliative Medicine Fellowship, along with Hedieh, who you just heard from, who is our associate program director as of this year and has been a wonderful addition. We are going to do a whirlwind tour of the fellowship here. This is a picture of our current class, many of whom are seated right in front of us. And I'm realizing as I talk about this, our current fellows are going to keep us honest about the program overall. We are going to try and talk about where we have been, where we are now, and where we are going in these 10 minutes. And just for a little bit of historical context, this fellowship was started not by me. In 2010, this has been an ACGME or formally recognized subspecialty since 2008, and so we were relatively early in starting a fellowship program here, largely thanks to Steve and other people who preceded my tenure here. And we have trained 65 fellows since then, and so we used to just train a handful of adult fellows, and then about 6 years ago, as Steve mentioned in the timeline earlier, we added a pediatric track that is very much needed since the workforce shortage in pediatrics is even more extreme compared to the adult field. And then we also added a combined fellowship that's geriatrics and palliative care together. So there's one fellow per year who spends their first year doing geriatrics and their second year in our palliative care cohort. And so we have a class of 7 fellows per year at this point, a lovely size, and it could always be bigger. And maybe worth noting, as I look at the fellows in front of me, that most people who do palliative medicine fellowship have been trained in internal medicine or family medicine, and we are really fortunate to be able to train people from all specialties. So that includes people from neurology. You heard from Kwame earlier. We have a general surgeon and a psychiatrist. We've had anesthesiologists. I think that really adds to the richness of the learning environment in our class. And then, also for us as faculty who have the luxury of getting to learn from people who have trained in lots of specialties. And I think kind of tying in with the earlier presentation helps us form collaborations with other groups when we have a neurologist leading the neuropalliative care efforts, for example. The governing body of medical education sets many requirements for the clinical year that our fellows spend with us, and so there's not that much leeway, but we do have some control over how our fellows meet those requirements, and so we get to kind of set our program aims and strive to meet those. We generally are trying to train people who are going to be leaders in the field, and that includes clinical practice, certainly, but also includes education, social justice, and research. We spend a lot of time, hopefully it feels that way to the fellows, really focusing on resiliency and well-being also. I think we're probably preaching to the choir here in stating that doing this work can be very emotionally intense, and for many of our fellows, they're coming from an experience where some portion of their patients have serious illness to suddenly having all of their patients have serious illness. And so we're really fortunate to have a robust resiliency curriculum to give them tools to manage that this year during that transition, and then also for what is hopefully a long and meaningful career over time. As Hedieh mentioned, we have lots of efforts to focus on diversity, equity, and inclusion in our fellowship, and that comes through both in the structure of our program and where our fellows spend their time in their didactics curriculum, and also in whom we decide to recruit and train here, and people who share those values. And then lastly, this has been a theme already today around interprofessional collaboration. And I think a real jewel of this program is that our fellows spend lots of time with different social workers and chaplains and nurses and pharmacists on different teams and really get to do bi-directional learning with each of those other professions. We could spend all day talking about the details of this program, and I will spare you that excruciating process. But I think Hedieh and I just wanted to share some of the highlights of this program that we think makes it different from our peer institutions. And really a thing that I think brings fellows here for residency training and for fellowship training is just the breadth of clinical exposure that we offer. And I'll show you a picture of some of those places in a second, but we really give people the chance to train in lots of different health systems, in lots of different environments, where they take care of patient populations that are really varied in their kind of demographics and social needs and all of the other ways in which our patients and families bring different life experiences. We've talked a little bit about focusing on social justice, both in our kind of long-term recruitment efforts and in our fellowship didactics curriculum. We offer a social justice track, so fellows have the option of focusing on that over the course of the year, in addition to the curriculum that all of our fellows get over the course of the year to make sure that they kind of have the tools and awareness to think about whether and how we are providing equitable care, and when we're not, how to work on that. And then we are also very fortunate to be part of a global health consortium. So GPEC stands for Global Palliative Education Consortium, which is a global health pathway that we do in collaboration with the palliative care fellows at Tulane and at the Harvard program in Boston. And so that is a virtual collaboration based on obvious geographic restraints, but is a really nice chance for our fellows to meet other people with similar interests and then spend some time at Navajo Nation or at some of our other global health sites. We've talked about interprofessional training, and we'll talk more about that in the Where We're Going section here, and resiliency training as well. And I don't actually see Naomi here at the moment, but just want to give credit where it is due. Naomi Sachs, who's one of our inpatient chaplains, really expertly leads this resiliency curriculum and has for a number of years. And I think both gives our fellows some concrete tools for managing the things that come up over the course of the year. And then, as maybe is evident by where our fellows are sitting together, I think provides nice scaffolding for fellow cohesion so that they kind of serve as each other's support group over the course of their fellowship year and sometimes for many years beyond that. You were talking about broad clinical training, and I just put some pictures up here. So our fellows go to lots of different sites. We are probably not going to add any sites when I think about where we're going. We're at the ratio of like maximum breadth of training without spending all of your time learning the EMR and where the bathrooms are at each of those sites. The top left is our children's hospital, where our PEDS fellow spends most of their time and our adult fellows spend a couple of weeks. The middle is Parnassus, of course, where we are now. Kaiser Oakland is where our fellows spend a month so that they get to see the Kaiser system and take care of the Oakland patient population, which differs in a number of ways. The bottom left is San Francisco General, which is our county safety net health system and a level 1 trauma center, and really an experience that I think sets us apart from peer institutions in terms of training. There is not another one nearby or even not nearby that offers that as part of their training. The middle on the bottom is the VA, which is generally kind of the educational jewel of the program because there's great clinical care and great teachers and a little more time to focus on the teaching part. And then the bottom right is just a picture of homes in San Francisco, as our fellows spend a fair amount of time doing home hospice visits with By the Bay Health, which is our affiliate. I think that was on Steve's timeline, and starting in 2015 or so. Their CMO, Kai Romero, happens to have been a fellow here, and many of their other physicians trained with us as well, which also sets up some nice collaboration in terms of their investment in teaching our fellows. And just to give a sense of where people go after doing fellowship training with us, in full transparency, this dark blue, more than half, represents people doing academic practice, and a very significant percentage of our fellows are doing their academic practice here. Many people take the UCSF as you can stand forever quite literally and stay on with us after fellowship. The red is people who do hospice. As I mentioned, a number of people end up working for By the Bay Health afterwards and are still kind of connected to our fellowship. The lime green is non-hospice palliative care work, so plenty of people who go into community palliative care practice. Even when they do that, you can see in this little image on the right here that even for our graduates who are going into non-academic practice, their jobs do often involve a component of leadership or program development or education or quality improvement, that the demand for growing palliative care programs across the Bay Area and elsewhere is still really high, and people consider our fellows to be well-trained and up for that challenge. And so even for our non-academic graduates, they're often doing a lot of good work to grow programs and provide good care where they are. And then the teal is actually people who are doing additional training, which I wanted to share because that seems like a strange thing after a fellowship, but many of our fellows are doing palliative care training as part of a kind of well-crafted career trajectory where they're going to go on to be champions for cardiology, where after they do cardiology fellowship, or transplant hepatology, or interventional pain. And so we really, as I mentioned, kind of relish the opportunity to train with people who have done that already or who are going to go on to do that and make real contributions in the field that way. I'm realizing my time is short, so I'm going to speed through this. That's where we've been and where we are. There are lots of things that we want to do, and some of them may very well take us 25 years or thereabouts. Some of these things are happening already, so it may have been mentioned that we have a faculty member who's going to provide a narrative medicine curriculum for our incoming fellows, for example. We've tried to focus on collaboration with other programs, especially our neighbors to the south, who also do very good work and with whom we tend to share fellows and colleagues over time. And I would say the other areas of future aspirations are very much aligned with our core tenets that I showed in the very beginning. And I think Irene Higginson's and others have talked about the importance of research in the field, how we know some stuff, but there's so much more that we don't know. And many of our other Department of Medicine fellowships do include research time, and our fellowship year is very clinically heavy. It's only 12 months for an entire specialty, and it's really hard to get in-depth research experience in that time in addition to people's clinical responsibilities. And so we would love to have a research track specifically for palliative care as well. I think because we don't have one, it makes it hard to recruit fellows who are interested in research, and vice versa, that we may not be as attractive to future fellows who want to do research because we don't have that track. And so that seems like an important piece over the next 25 years to add to really support those fellows, to attract those people to come train with us, and then also just to grow the capacity of the field. I think Steve Steinlein talked about the many ways in which we have contributed, and we certainly are contributing in research and could always do more. And I think we certainly have the mentorship and project opportunities across all of the sites that I mentioned. So certainly plenty of capacity to support that. We've talked about the program's focus on social justice. We have a couple faculty members who have done a wonderful job of helping us develop that curriculum, and we're hoping to build on that by having a track supporting scholarly development, potentially including some training in advocacy and policy to extend the reach of that beyond just the walls of our program. Interprofessional training might truly take 25 years, and I think would be a really meaningful contribution both to our program and to the field as a whole. So I maybe didn't say this in the beginning, it may have been obvious that we are only training physicians in this fellowship program. We do sometimes have chaplaincy interns and social work interns who join us and get to work with the fellows, and that experience is wonderful. And there are programs that have truly interprofessional fellowships where the physician trainees are with the nurse practitioners and the chaplains and registered nurses and everyone else. And those programs really have rave reviews on all sides, that the learning environment that provides, and I think the kind of value statement that also provides is really meaningful for all of those trainees. And so we would love to have that. And I think we've also talked so much about the workforce and how important it is that we work in teams for high quality patient care and sustainability for all of us. And when we're only training physicians, that means that all of those physicians who go out to work in the world, if we haven't trained a similar number of the other disciplines, we're not going to be able to sustain that ratio of interprofessional team members. I don't even want to put it this way, like to physicians, but we're not going to be able to have teams look the way that we want to if we're not scaling up our training for everyone. And so we would love to be able to do this at some point. I'm going to say like 3 words about this slide because you just heard about our programs to very slowly but hopefully very steadily recruit people from underrepresented backgrounds into the field, because we really do want to strive to have our palliative care workforce reflect the patient populations that we take care of. And I think as an institution at UCSF, really big strides have been made in terms of our medical school class, our residency classes, and hopefully it's only a matter of time before that makes its way up to fellowship and faculty and kind of the School of Medicine as a whole. But we really want our fellows to represent the patients that they're taking care of, and we think about other ways that they're providing high quality care to people who may have a marginalized experience, including around language skills that people bring in addition to racial and ethnic diversity, and just the diversity of life experiences that people bring. We try to have fellows who come from rural settings and urban settings, and trying to reflect our patients and families in all of the ways that we know that that's important. And I'm going to stop there and hand it over to Allison.